right, I think we can get started. We have close to a quorum here. Welcome everyone to Geriatric Medicine Grand Rounds. It's getting to be toward the end of the academic year, if you could believe that. And as you recall from prior years, our last 4 Geriatrics Grand Rounds are always our wonderful geriatric medicine fellows presenting on a topic of their choosing. Today, to kick that off, Jessie Katz is going to be presenting a talk to us on ageism, which is something he's done a lot of teaching on. He can tell you a little bit more about that. I'm going to turn it over to Jessie. I'm excited for your talk. And because I like to celebrate all of the fellows, and I think it's important to do that, I'm going to ask if you don't mind in your introduction of yourself and your topic to mention where you're headed next. Not yet, you can't go there yet because we really don't want you to leave, but if you can let everyone know what comes next after fellowship.
Thank you, Kate. I am heading over to work at a PACE in Cambridge, Mass, and I'm very excited. I've been very happy to have some really great experiences at PACE out here, and it's just, I'm excited to be able to move on to that after I finish fellowship. So good morning, everyone. Thank you all for being here. As Kate mentioned, this is a topic that I've had the opportunity to learn a bit about. I worked on a project in residency about ageism. I'll briefly mention that, and I've had some really great conversations and learned a lot as I've researched this topic. So I'm hoping this can be engaging, interactive, that we can all kind of share stories today about our experiences and learn a little bit together. So objectives for today, I'm going to define ageism. I want us all to kind of, by the end, understand some of the impacts of ageism within the healthcare system, helping us feel a little more motivated to make some changes. Identify ageist language, and workshop some skills and utilize tools for combating ageism. So we'll talk a little bit about some of the most common and well-used tools that are available, and we can kind of practice a little bit during this session. And as I said, I want this to be interactive, so please, questions in the chat. Don't hesitate to interrupt me and turn on your mic and just speak, share some stories. I'm hoping this can really be engaging conversation for everybody. So just to mention, this was my team that I worked with in residency on our ageism research. We looked a little bit into the impact of education on ageism on residents throughout residency, and if there was a sustained response in improving ageist attitudes, depending on how early you intervene. And it was a small sample size, but it did kind of show that the earlier we can address ageism, the better within education and in physicians. And it was a really wonderful group. So I, of course, am mentioning my team here. So to define ageism, it's a term that was coined by Robert Butler in 1975, who was the first director of the National Institute of Aging. He defined it as a process of systematic stereotyping and discrimination against people because they are old. Once this term was out there, conversations and research around the topic have been pursued, but quite slowly. More recently, as we know, with elderhood coming out, it's kind of sparked some more interest in the topic, which has been wonderful to see. And so we've been able to really have more conversations, see more tools, and a little bit more attention to this important issue. I was wondering if people have any insight or knowledge from their experience on the impacts of ageism in the healthcare system, kind of at any level. And I'd love to hear if you could turn off their mics or throw something in the chat.
Hey, Jessie, this is Sophia. Excellent talk. I look forward to hear what you have prepared for us. I think that ageism negatively impacts the health of people because based on chronological age, people are denied access to a standard of care therapies that could potentially change the course of disease and also change life expectancy and quality of life.
Great. Thank you, Sophia.
Hey, Jesse, good morning. It's Chris, co-fellow. And I think a big example that we've discussed previously too is like, I think just research in general, where I think always our age cutoff is like 75 or 70, when in fact, like people live plentifully into the 90s, and we exclude the ability to inform good opinion, because most times we just make a cutoff point because of number.
Right, and this just kind of reinforces the lack of knowledge people have about older adults, and further makes us more ageist, and makes us kind of address and handle our patients' health in worse ways. So some other comments here on media, movies and commercials. Taunton, that's a great comment. My next slide, we'll get into that. And not really healthcare, but birthday greeting cards. Can you explain what you mean by that?
They tend to focus on being over the hill or being wrinkly, and it being an incredibly negative thing. It's hard to find a birthday card that really celebrates aging unless it's for small children.
Great point. It makes it into a joke, or finds some way to laugh at it, or we made it here and our bodies are sagging and we're not happy about it. We wish we were younger. Another comment here. We conflate increasing age with a disease process like Alzheimer's disease. Right, so these assumptions that we have that age is directly associated with illness and loss of function, and that's normal for everyone. And so I'll kind of show some of what I was able to find here. So I'm going to kind of go through some of these different, each of these different effects that we see in the healthcare system, starting up at the top here, going from light to dark to follow it. So on the patient level, increased patient passivity, right? So if we're talking to our patients and we're either ignoring them, or we're talking down to them, or the language we use, the tone of voice, they're going to want to engage less. Subsequently, we know that it's associated with poor physical and mental health, slower recovery, worse quality of life. There's associations between ageism and elder abuse. It's been found that countries with higher life expectancy have less ageist attitudes. This is an association. So whether it's because they have higher life expectancy, so more exposure and less ageist attitudes, or the other way around, that these less ageist attitudes into the culture have supported a higher life expectancy because we take better care of our older adults, it's hard to say, but I thought that was an interesting association. There was one study that estimated $63 billion cost annually in the healthcare system due to ageism. They looked at certain medical conditions and how they were addressed within older adults, and if it had been handled differently due to certain ways they looked at it to estimate a pretty significant impact on the healthcare system. Speaking from an educational standpoint, we know that as students and residents and learners have ageism around them, they're going to be less interested in working with older adults. So of course that makes us question, does that mean that if we can get people to be less ageist, maybe we'll have more geriatricians too? And we all know we need that. And so there's, at every level, ageism impacts the healthcare system, and it's all negative. I think I see another comment here as well. Great, intersectionality, I'm going to get into that as well later in the talk, so thank you for that point. I'm going to show a video now. The audio should be working, and I would like you to kind of reflect on it. It's a little funny, and then we'll talk a little bit about the ageism that's pretty obvious here.
So, what are you doing here? You've seen everybody, nobody found anything wrong with you. And between their workups and mine, there are no more tests to run.
Yeah, but I know
Mrs. Warner, your main complaint is you're tired. I get tired too. It's called getting old.
Dr. Budd, that's not what this is. I am sick. I've had to give up my job because I was too tired to do it.
How'd you get here?
I flew.
No, to my office.
A taxi.
And from the taxi?
But how did I get from the taxi to your office?
Not a hard question.
I walked.
Right, you walked. You're not sick, Dorothy. The people I see can't walk. They can't swallow. Some of them can't breathe. Look, don't take this the wrong way, but have you ever thought about seeing a psychiatrist?
I have seen two. Here are their letters. They both say there is nothing psychologically wrong with me. They believe it is physical.
What the hell do they know? Psychiatry is not a science.
Then why did you suggest I see one?
Because what you have is not scientific. What else was I going to do? Send you to New Mexico to a shaman? There's nothing wrong with you, Dorothy, except what happens to all of us. In case you haven't noticed, you're not 30. Take a cruise, Dorothy. Go to a hypnotist. Change your hair color. My wife became a blonde. She's a new woman.
So I would like to hear anyone's reflections on that. If it brings up any personal experiences, or, you know, this is definitely very direct and obvious. I think Golden Girls, the whole show, I recommend it to everyone. It does an amazing job of addressing all types of discrimination. But this video really, really did a good point of addressing ageism. Yes, again, intersection, great point, right? Sexism as well is part of this, and that's important to address. Thanks, Angela.
This is Angela. This is
yes.
Angela again. Just, you know, something I deal with in my clinic. I mean, there is, and you know, there is an art to saying like there are things that happen as we get older that are okay to say. Like we do slow down, our cognitive abilities change a little bit, you know, but there are definitely things that are abnormal aging. And we, you know, need to take those seriously and differentiate those between normal aging. And I think this was a great example of how not to do this.
Yeah.
I mean, obviously it's comedy. It's supposed to be absurdism. So, yeah, don't do it that way.
Thanks, Angela.
But yeah, but there are, you know, ageism, you know, I think the opposite of ageism isn't ignoring that we don't age. But
yeah, education is an important point. We need to differentiate what's normal and what's not, and I think that helps our patients as well, who definitely, you know, I'll break into these different types of ageism now, self-ageism being an important piece. So these 4 types of ageism were also created initially by Robert Butler. So just to briefly go through them: explicit ageism being with knowledge of bias, someone's intentionally being ageist and they know what they're doing. Implicit ageism, where they're not really aware as much of the bias that they have, which I think, you know, definitely impacts us all. Institutional ageism, so this is practices that discriminate against individuals or groups because of their old age. I think research falls under that category, and lack of certain requirements, which I know has been changing. And then personal ageism, which is on the individual and kind of the thoughts and ideas that contribute to this. And I think that probably all of these were part of this last video that we watched in one way or another. And it's good to sometimes have the terminology to break down what we're seeing and what we're feeling to help us address it better. Any other thoughts before I move forward? All right. Yes, the intersectionality. This has already been brought up a couple times, and I do think it's really important to address. To define intersectionality, this is the ways in which systems of inequality based on gender, race, ethnicity, sexual orientation, gender identity, disability, class, and other forms of discrimination intersect to create unique dynamics and effects. And oftentimes it will lead to create further barriers for people who are part of multiple groups like this. And so, for example, in this video, sexism likely also played a role, and probably disability as well, right? She had a medical condition that was possibly affecting her ability to advocate for herself and the way that she was being perceived, on top of course, her age. And so it's really important that we address that our patients and their age is not in a vacuum, and our patients are a lot more complex. I kind of see intersectionality as a greater term for multi-complexity, in a sense. So as we move forward now to talk about some of what we can do and what initiatives exist for addressing ageism. I'm going to briefly mention some of the initiatives that I found that I thought were interesting. This first one on the left is the World Health Organization. They started an initiative over the past few years and published a report in 2021 called the Global Report on Ageism. It has various initiatives and tools to identify and combat ageism at a lot of different levels, which I thought was really interesting. Its Decade of Healthy Aging is a UK-based initiative. Its goal is to add life to years, is their kind of slogan, as opposed to adding years to life and not just focusing on that, but helping people maintain good quality of life over the next 10 years or so. And it did also have some good references and resources. And then, of course, Reframing Aging, which I'm sure many of us are familiar with. This was founded in 2012 when research began to assess attitudes about aging in the US. And they now work with organizations and communities at lots of different levels to impact the way that we think about, address, talk about aging. Helen Fernandez presented on this previously, and I'm sure many of us know her. And their resource guide is called Gaining Momentum. And I will talk more about this. And so really I'm focusing on the first and third year initiatives. They have some really great tools that we'll be spending some time on now. So combating ageism. I'm going to go through 3 evidence-based strategies that were breaking from the World Health Organization. And this is kind of the umbrella under which our primary focus will be, is mainly educational activities. That's the primary one that we'll spend time on today. We'll talk about these, we'll practice a little bit, and we'll think about how we can utilize some of this in our daily practice as well. So the goal of these educational activities that exist is to specifically enhance empathy in learners, in those people that we're working with. It's been shown that with increased empathy, the ageist attitudes kind of fade a little bit. It allows people to relate a little bit more and see the variability amongst older adults. There are a lot of resources that they can offer. Role-playing simulation VR, and there is some data to suggest, as I mentioned earlier, that the earlier we can start, the better. So as we're working with medical students, especially, it can be great to just bring up small things, to point out little tidbits of language or the things that we see, so they can start to be aware of the presence of ageism and the impact it has on the healthcare system. Now I'm going to go through some of the tools that we have. So this is one tool in Reframing Aging. It's from the Quick Start Guide. They have some words and cues that they give, and then some substitutes that you can offer. And I would love to hear people's thoughts on each of these as I bring them up. So the first one being, right, we hear this tidal wave tsunami, similarly catastrophic terms for the growing population of older people. And, you know, I think to us, it may seem obvious that those are not the most positive terms, but you know, it's common terminology that people use, so it's important that we're very aware of this and that we have ways to respond to it or alternatives to present to people. So as Americans live longer and healthier lives is a nice way to say it that communicates the same message without putting that negative spin on it. Choice, planning, control, other individual determinants for aging outcomes. We kind of make it that it's our responsibility as a whole for how we address aging and not putting it on the individual, which can kind of contribute to guilt and negative perspectives. I think one of the things to keep in mind with this one is, I'm going to talk about Elderspeak in a little bit, but that kind of let's and we. This is talking about it when we're talking on a greater scale about how we're addressing medical issues as a whole, but rather than, you know, going up to someone and saying, how are we doing today? Which is one of the examples of Elderspeak that we want to stay away from. Right, specific terms, we're pretty good here at using older adults, older people, inclusive terms as we get older, as opposed to the othering terms that we don't want to separate. We don't want to make it seem like they're a separate group. Older adults are a group that we're not part of, that they're something that we don't want to be, that we want to avoid. We know that there are many wonderful things about aging and getting older from our experience too. The language like struggle, battle, fight, conflict-oriented words we want to more stay away from. I really liked this sentence, this building momentum metaphor. Aging is a dynamic process that leads to new abilities and knowledge we can share with our communities. So there's a place for older adults in our communities. There's not only a place, but we grow and thrive as we include older adults in our communities, and as there's a lot to learn. Explaining what ageism means, right? We want our patients and those we work with to understand what ageism is, so they themselves can be advocates and understand it. And speaking on kind of a grander scale, having concrete examples like what we can do to actually combat ageism. So there's the language piece, and I'll talk about some of the other tools, but this is what we're addressing in this talk, is having more concrete solutions rather than saying, oh, it needs to be fixed and kind of not doing much about it. Anyone have any other terms or words or language that they've kind of come across that they think maybe we should all be aware of, or that they found to be problematic?
Hi, Jesse. This is Mary Pat O'Leary from the Area Agency on Aging.
Wonderful.
And I think nationally, folks are trying to get away from, quote, senior centers. There's a lot of language around senior services, senior centers, that it just, instead of saying, you know, the full gamut of supports and services for older adults or as Americans are living longer. And secondly, I would say that sometimes, Jesse, what I've found is the terms like tsunami, those catastrophic terms, are used to put fear and force people to make emotional decisions about funding. And that is pretty destructive. Thank you.
Yeah, thank you so much. I see a comment in the chat. Older people refer to Alzheimer's as old timers, not frequently. Yes, I think I thought that's what it was when I was little. So yes, definitely. These are jokes, right? There's a lot of jokes that people make about aging and to kind of lighten it, but in reality, it creates more problems, and it makes people avoid wanting to talk about a lot of important things. Anything else? They actually have another correction.
I hear a lot of the use of words like cute and sweet and amongst healthcare providers to refer to older adults. I see that pretty much every day.
Thank you. And that brings us into Elderspeak. Thank you, Kate. So to define Elderspeak, it's an example of something that we're not necessarily often aware of doing, right? It's how we change our tone, the words that we use when we're talking to older adults. And it can be an automatic thing. So some examples of this: tone of voice, changing our pitch or tone, talking in higher voice, exaggerating words, simplifying the length and complexity of sentences, speaking more slowly, using limited vocabulary. So basically simplifying and acting like we think people are stupid. They can't understand us. And people get very offended by it, but they're not necessarily going to speak up, especially if they're used to it. And so this can really contribute to kind of the learned passivity that people have, this learned helplessness, where they kind of learn to accept it. How many fights are people going to really want to pick? And so Elderspeak also falls under the umbrella of microaggressions for many people, defined as indirect, subtle, or unintentional discrimination against members of a marginalized group. And I'm going to show a little video on microaggressions and how we can address those as well. But just to speak about some of the impact of microaggressions for those who aren't familiar, right? These small little things, whether it's a word that we use, the way we talk to someone, that to us doesn't seem like a big deal. And if someone said it to one of us, maybe we wouldn't think twice. But I've heard it described as like mosquito bites, where you get bitten once or twice, you're not going to think much about it. But you get bitten constantly, it's going to drive you crazy. And it's going to really, really impact your quality of life, your happiness, and your ability to interact with people. And at a certain point, you're not going to bring it up every time and try to deal with it. And so microaggressions really build up. And so this next video talks a little bit about how we can address those.
So, how can you help address microaggression when you see it happening? When you notice microaggressions occurring, interrupt the situation. You could 1. Ask questions to get at any underlying assumptions.
Thanks. Why did that surprise you?
2. Acknowledge what happened to the person affected.
I heard that comment and it didn't feel right.
3. Be an active bystander and explain to the person saying or behaving in a harmful way why their actions had a negative impact, even if unintentional.
You did really well on the skills checkoff today. I knew you would.
Addressing microaggression is an ongoing process.
I hope that's helpful. And now a little more practice that I'd like to get to. This is also from Reframing Aging. They have some really great tools in their toolkit. And so I thought that this could be fun for us. So they have this one tool where they've created these fake tweets on Twitter that have the ageist language in them in one way or another. And then they have steps to go through for how to reframe it, how to identify what's problematic, or as they call swampy in the language. And I'd like us to just kind of look at one together and see if people can kind of speak to what they see as problematic in this one. So I'll read it and I'd love to hear people's thoughts. So check out this important new program in Nevada that is helping to bridge the ever-growing gap between teens and the elderly. Makes an assumption, Angela. Yes. And what is that assumption that they're making?
Yeah, an assumption that I guess that there is that there's a gap that's ever growing.
Mm-hmm.
Kind of a pet topic of mine is you can go back to Plato and Aristotle when they were complaining about the kids. So I don't know if it's new, but that's yeah.
Yep. When people see things in tweets or wherever and they just believe it, they just listen. So there's a lot of power. The use of the word elderly. Yeah, and do you think you could speak to why you think that's problematic? Specifically in this, I know we talked about it a little bit.
Yeah, exactly. Just as you said, it's a negative, has negative connotations. So, and as you talked about earlier, there's other words that would probably be better to use.
Yeah, and it says the elderly too. Also, I think it kind of very much makes it into a group. So the elderly and gap both are, as they've put, are likely to activate older as other model, reinforcing the us versus them. The ever-growing gap, also, as they put it, could cue fatalism, which Angela, you kind of addressed. People have always kind of been saying this, suggesting that no problems could ever successfully address this issue as well, the way that they phrase it, and kind of creating this hopelessness that it's a problem, we're never going to fix it, why should I care? Okay, great, thank you. I'm going to share another something from recent news that I found to be very frustrating, as I'm sure people saw for Dianne Feinstein when she was out sick for a while and she wasn't able to work, and there were so many people saying that she should retire, but they were saying it's because of her age. They were saying that there should be an age limit for politicians. And I found this to be very frustrating. You know, there are other things to be said, but the age limit is not the solution here. And it is quite ageist, and there was just a lot being said about that. So just sharing, we know it's everywhere, we know it's in the media, and very, very recently we were seeing this. Looking at this the fourth article here, there was some language in here as well that I thought was worth mentioning. So with many US leaders being well into their senior years, it's no surprise that Dianne Feinstein, et cetera. And I think that, you know, this is making that assumption that when someone is in their quote unquote senior years, it's assumed that they are going to have health issues and fail and be unfit to hold certain positions. And again, these are legitimate news stations that are sharing these things. So it's very prevalent and out there. So aside from educational activities, the second tool that has been brought up is addressing policy and law. I'm not going to get too much into this, but they have some really great tools in reframing aging that break down specific components of when you're writing policy, when you're addressing certain policies, and the language to use that can be most effective. And they don't say tsunami is one of them that you should be mentioning. But they do mention how to phrase things effectively from what they've seen from their research, and some pretty cool tools that I really enjoyed looking at as well. I did think that, interestingly, the ACLU does not have a page related to age discrimination. I had a hard time finding much that they've done at all for age discrimination. There was something, I think, back in 2004 on their website that pops up when you search it. Does anyone else have any experience with policy or law or comments on what they've seen regarding ageism?
Jesse, it's Mary Pat again. I think it is arbitrary mandatory retirement ages. So saying it has to be this age and you're done, versus, should there be some, open-endedness if the person wants to work till 72 or 68 or 94 or whatever. But I will also say, and I was going to say it earlier, I am in my 60s. I'm not ready to retire, but I will tell you, young and not so young people continually say to me, when are you going to retire? And I'm not sure it's because they think I look like I should retire. Kate knows me, so, but part of it is sort of like, I still feel functional. I still feel creative. I still feel like I have purpose. And I'm not ready to retire, but I'm just really shocked at even people within the aging network in my office. So anyway, I just think it's really interesting that this is really important topic that we need for our own area agency on aging and the community. Thanks.
Thank you so much for sharing your experience. It's so important. And I think that when we talk about policy and law, we think about who created these in the first place and what their goal was in mind. And it wasn't to make the aging experience great. It wasn't, I wonder how much representation there was in these conversations for older adults to say, well, this is what we really want, or speaking on behalf of some of the groups. So it definitely reflects in the fights we're fighting now. Looking at some of the other comments, pilots have a mandatory retirement age. So right, all these mandatory retirement ages that, like, again, who decided them? There have been some interesting questions where physician retesting with age. Agree with Kay, we can't lose you, Mary Pat. Laws and regulations that are about safety for older people that deprioritize their autonomy and right to choose, right? Assuming that people, as they get older, are not going to make as good decisions for themselves or don't know what's best. And the saying, if you've seen one 85-year-old, you've seen one 85-year-old, it's true. And we need to make sure that everyone realizes that. Thank you all so much. The third, I'm sorry, yes.
Yeah, Jesse, I'm going to take the other side of it for a minute. Okay, first of all, I'm going to be 80 years old this year. And I just got a new grant. And but what I have to consider is, and I'm in good health. I bike, run, whatever, go to work every day, etc. But what I have to consider is, what can I honestly expect to do over the next 5 years? So not that things will fall apart, but chances are that they won't be the same 5 years from now that they were now. So I obviously wouldn't agree with mandatory retirement at age 75, but I think there is an issue that does have to be addressed in some way when you're looking at what are you going to be able to do for how long. Anyway, just a comment.
Thank you. Yeah, and I mean that's why these conversations are important, and we need voices of people who are experiencing this themselves to speak, so that way we can come up with thoughtful policy and ways to address older adults in the workplace. Okay, I think there's a difference in planning and having backup plans versus assumptions that you can or can't work. Right, so it's the assumption being made versus allowing you to make a decision for yourself or make a plan with your team about what your future working may look like in the next 5, 10 years, etc. And the third category here of interventions being intergenerational interventions, and I think these are really fun for those of us that have heard about them, aiming to foster interaction between different generations, which has been shown to reduce ageist attitudes, and combined with education, it's even more effective. Just one study that I found was this student-initiated longitudinal interprofessional intergenerational home visit program. So they had healthcare undergraduates and high schoolers visit older adults for home visits every 2 weeks over 6 months. And they found that in the scale, one of the scales that they were looking to measure ageist attitudes, that it improved significantly over the 6-month period just by exposure, by spending time with these older adults. And as I know for many of us, our reason for going into geriatrics was a connection with some older adult, some experience while prior to becoming doctors or sometime in our lives. So, and again, as I mentioned before, further exposure to older adults, maybe we'll get more geriatricians too. Any other interventions people have heard of from this group? Because I think these are really fun.
Jesse, this is Elizabeth. Yeah, a number of years ago, there was an intergenerational Tai Chi pilot that one of the junior faculty in the School of Nursing spearheaded. I don't know whatever happened to that, but that's another example. So people, it was for teens and older adults, not necessarily related, to come together in the same space and do a Tai Chi class.
Thank you.
Sure.
Yeah, David, I see your hands up.
Yeah, thank you. This is just a very interesting discussion, and it has me thinking about my own behaviors, among other things. I'm wondering about ways to expose all manner of folks, healthcare professionals, middle-aged people, young people, to exemplars of people who continue to do outstanding things as they become older, people who may develop new skills as they get older. And I had a living example in my mother, who wrote her first book after she was 80, and then went on to write another book. And so it just, and her example affected a lot of people, and probably changed a lot of minds about what older people can do. And so I just think the exemplar might be something to consider in combating ageism.
I think that's great, right? We want to see representation, and we talk about in the media and the power that has. TV shows, I think about Grace and Frankie. I loved that show so much. For people who haven't watched it, I think it did a fantastic job of showing what all the things that people can do in older age. They have active sex lives, they start businesses, they go through relationships, they move. and they do drugs. I think that it's that representation, especially for people who accomplish things in older age, it'll not only allow for those of us who are younger to see the variability and what healthy aging can look like, but it also for those people who are themselves nearing older age or getting older, they can also might feel a little more motivated to reflect and see their future a little bit differently. So to summarize, ageism is complex and deeply ingrained in our society with many health-related negative downstream effects. Education and exposure are key in combating and decreasing ageist attitudes. And a lot of what we're doing today and what I was hoping we could do, which has been wonderful, is reflecting on our own experiences, our own language and actions, and then finding ways to correct it so we can set examples for those around us. And there are tools that are research-based that are effective for change. And to briefly, I have them here at the end of my presentation so we can distribute this. You can easily search it too, but the World Health Organization's Global Report on Ageism, Reframing Aging are two of the really big ones. The Gerontological Society of America has modules called the Ageism First Aid, which also seem to be pretty great. And I have a video here for if people want to watch afterwards that talks a little bit about Elderspeak some more, so that way you can see some firsthand experiences and reflect a little bit, because I think it's very easy to, it's hard to identify in ourselves Elderspeak, and it's important we reflect on if we could see how we're talking, if we would want to be spoken to like that. Thank you all so much. We've got a little bit of time still if people have more comments or questions.
Thanks for this presentation, Jesse. I was wondering how you think you'll take this to your next job and what sort of things you think you'll implement. And then while you're thinking about that, I think that we all just need to plug away at this and when we're working in clinical settings, speaking up and making changes, recognizing when we're doing it. I've changed the language I use when I write. I often interact, not often, but sometimes interact with congressional staff or write testimony. And I did that just this week, and I had to really think about how can I make everyone realize that they are also aging. And this is about us and the healthcare system we want for ourselves, whether we're 20 or 40 or 70. And so the changes we make in geriatrics education and workforce build up are for all of us. So anyway, those are thoughts I have, but I'd love to hear where you're taking this next.
Thanks, Kate. Yeah, I mean, the tools that Reframing Aging has are so well designed and easy to implement in just a few minutes that I would love to have kind of periodic, short little 15-minute sessions or 10-minute sessions even, where I can work with the people around me. We can just do one task together, have a brief conversation, and keep everybody engaged and thinking. Because I think that something like that, it will linger. People will continue to process over time. And I think on the smallest scale, that's something that's pretty easy to do, even with a small group of a couple people. I think it can have an impact. I do work really hard on correcting my patients, teaching them about ageism. When I hear their language, I encourage them to differentiate the difference between normal aging and what's not, and that they should be bringing things up to me and not just assuming it's normal. That way we can make sure they're getting the best care and being listened to. And I do teach a lot of my sessions to family members as well about ageism to help kind of spread that. And people are really receptive and find it to be very valuable. See some comments here. Joe said, I feel like it speaks the challenges of arbitrary retirement ages that is particularly individualized, confronting an extra layer of bias regarding who and how people should work. In contrast to the working older adult, I have patients in 40s to 50s at the VA that have numerous orthopedic injuries that plausibly limit their ability to work in their field without significant quality of life limiting pain, where I've had to confront my own biases towards productivity. It's remarkably hard to advocate for them. Thank you. And Elizabeth said, Barb Cochran has shared that Cindy Perry is the nursing faculty member who did the Tai Chi pilot study, if anyone wants to look it up. Thank you.
Oh, is it just, oh, never mind.
Jesse, it's
yeah.
Mary Pat again. I would also say about housing. So, you know, living and aging is a continuum. And I really appreciated what was in the chat about younger individuals who have had orthopedic injuries. It is almost an impossibility to go up the pod stairs, some of these very narrow townhouses. And, you know, how can we have affordable housing, but how can we also make sure that a person is able to live healthily in place, get the services and supports that they need? Some people can go to a community center for an exercise class. Some actually need the facility, like very much like PACE. They need wraparound supports and services. So I just think it's very complex, but I don't think it's impossible. Thank you.
Thank you so much. Thanks, David, for your comment as well. Oh, sorry, Angela. The gray square, I think, is my chat that I have opened, so I moved it. So you should be able to see the QR code now. In case it or encourage universal design that doesn't feel institutionalized. Okay, do you want to speak a little more to that? If you can, I don't know if you can.
I can now. I'm not walking a dog or biking. Oh, of course, my camera's not working. Hi. Yeah, no, I think to your point, Mary Pat, in my prior life, when I was very into a world of, you know, thinking of home safety and home design, and even just our institutions in themselves, right? I was very stark of this, of how different it is walking into Children's Hospital versus walking into even our VA, let alone Harborview or our other adult hospitals. You know, there's this definitely welcoming feel, but there's a way about how these places and things are set up so that they're naturally a fit to changes to our mobility or our ability to access certain spaces, potentially with mobility challenges, versus just retrofitting them with bars and seats and whatnot that just feel very medicalized or institutionalized, which oftentimes I think sets up a lot of internal barriers to wanting to utilize those things, ask for those things, and engage with using these durable medical equipments. And so that's part of the kind of movement behind universal design and how we think about, you know, setting up our buildings, affordable housing, and let alone our institutions.
Jesse, this is Elizabeth again. To what extent do you think this is a culturally driven phenomenon, you know, US based, and what could we potentially learn from other societies where older adults are actually held in high esteem?
Yeah, thank you. I was talking with someone yesterday about this who brought this up, how, you know, in the US, we really, it was just a patient of mine who was saying that he's been having a hard time with his father, who is in a memory care unit, assisted living. He has mild, moderate dementia, and I think he knows in other countries that they do their best to keep the family around, and the kids are fighting to keep their loved one at home as they age. While here, I don't think it's just the culture that people don't want to take care of their loved ones, but it's very expensive and it's hard. You know, I don't know. I think there's varied cultures here in the US too. I think depending on what subgroup of different cultures you'll see here, you know we have patients that depending what bubble they're in, they will approach this a little bit differently. They will see older adults, as I think about in, Native American culture, in a lot of cultures, I know in Jewish culture as well, we have a lot of respect for older adults. And it's a really powerful thing to be able to learn from that wisdom as you see it in some ways, while in other cultures, it's kind of just, I can't afford to take care of you or something else. I think learning, I think that's the only thing I can think of. I don't know about specific interventions, but it's a really big problem, and I think money plays a really big role. I see a comment here. And Kay agrees. Tribal communities use the term elder as a sign of respect. Yep.
Yeah, I was going to say, Jesse, when I have also noticed this when I've traveled in various places, and back to the universal design, like when we were in Japan a couple of years ago, and how places were just fitted for all persons. Like it was irregardless if you were, and I was traveling with like a 20-some-month-old at the time. So I was very in tune with it, but it was like we would walk into like, public bathrooms, and it was clear that this public bathroom was set up for all types of people, irregardless of where you were on this age spectrum or ability spectrum or caregiving spectrum, right? And that just was very, and to the respect around that you just embrace it and acknowledge it, right? It didn't feel like, oh, you have to go to this special place over here.
Yeah.
Yeah.
Thank you.
Well, thanks again, Jesse, for this great presentation, and everyone for really good discussion. I think we need to keep talking and coming up with solutions.
Yeah, thanks, Kate. Thank you all, everyone. This was a great discussion, all I was hoping it would be. So I appreciate you all joining in.